Hello, everyone. I'm Lillian Kao, President of IFSO, and I have the pleasure of welcoming all of you together with Professor Guilherme Macedo to the World Digestive Health Day 2021. Today's program is a culmination of a collaboration of two international federations. IFSO, the International Federation for the Surgery of Obesity and Metabolic Disorders, and WGO, the World Gastroenterology Organization. Our theme for this collaboration for World Digestive Health Day is Obesity, the Ongoing Pandemic. The aim of this joint campaign is to raise awareness of obesity as the ongoing pandemic and the impact it has on the development of comorbidities and subsequently the effect on life expectancy, which is just as devastating as any infectious pandemic. I would like to take this opportunity to introduce my co-moderator, Professor Guilherme Macedo. He's the president-elect of WGO and currently serves as chair of the WGO Foundation. He also served as the American College of Gastroenterology, the international governor for Portugal. He's currently the head of the Department of Gastroenterology at Central Hospital São João at the University of Porto. I will now invite Professor Macedo to say a few words.
Thank you, Professor Lillian Kao, and it is indeed a pleasure and honor for us to welcome all of you to this World Digestive Health Day 2021, as you know, dedicated to the obesity, the ongoing pandemic. The fact is that this is an extraordinary and evolving chapter in medicine and surgery that prompted us, both WGO and IFSO, to build up this joint venture. And the fact is that also a major recognition of the importance of this topic, and also to the relevant role of those who have been engaged in this global health issue, is the United Nations Secretary General statement that publicly expressed the support and commitment to our project in addressing obesity for a sustainable and healthy world. So we have, and we believe that our faculty has created an outstanding program to keep you motivated and tuned in throughout these next hours to think and to reflect about how can we deal with obesity. Now I have to give also a special word of acknowledgement to our sponsors and partners who in fact made a very important contribution so that this project could be built up and shown to all of you throughout the world in this beginning of afternoon, at least here in Europe. Professor Lillian Kao, who will introduce the three panelists in our first session. As you know, she's the current president of IFSO, and she's a senior past president of IFSO Asia Pacific chapter and a senior past president of the Obesity Surgical Society of Australia and New Zealand. She's a senior consultant surgeon at Flinders Medical Center and clinical associate professor at Flinders University of South Australia. She has been involved in training surgeons in bariatric surgery nationally and internationally, as many of you know. She has been also at the forefront, along with her colleagues at the Adelaide Bariatric Center, in developing a very effective multidisciplinary program for supporting our patients in their weight loss journey. The program in Adelaide was one of the initial ones adopted in Australia and internationally, and the first to be used in South Australia. So thank you, Professor Lillian.
Thank you. Well, I think we're going to start the first session. And in this first session, we are going to discuss some of the hottest topics in obesity, including non-alcoholic fatty liver disease, cancer, and diabetes. So it is my pleasure, firstly, to welcome our esteemed panelists. Firstly, we have Professor Laurent Bieto from Canada, who is the clinical professor of surgery at Laval University, where he introduced minimally invasive bariatric and metabolic surgery. He's the director of the fellowship program there, and he's also the past president of the Canadian Association of Bariatric Physicians and Surgeons. So welcome, Laurent.
Thank you. Good morning.
Second on our panelist team is Nicola Di Lorenzo from Italy. He's the Associate Professor of Surgery at the Department of Experimental Medicine and Surgery, University of Rome, Tor Vergata. He's the former president of the Italian Society for the Surgery of Obesity. He's a member of the IFSO Executive Board and Secretary of the European Association of Endoscopic Surgery. Welcome, Nicola.
Thank you. Welcome,
Last
everybody.
but not least, I have Syed Hamid from Pakistan, who is the chairman and professor of gastroenterology at the Aga Khan University Hospital, Karachi. He's the member of the Executive Council of the Asian Pacific Association for the Study of Liver and currently serves as president of the Pakistan Society for the Study of Liver Diseases. He has been a long-serving member of the WHO Guidelines and Publications Committee and chaired the WHO Guidelines Development Group on Hepatitis C Treatment Guidelines, which was released in 2016. Again, a very warm welcome to Syed to the panel.
Thank you, Lillian, and a pleasure to be here. Thank you.
Very good. Also, we are counting with our three presenters that will address these three different topics that will be discussed later on. And so for me, it's also a pleasure to introduce Professor Helena Cortes Pinto from Portugal. She's a specialist in gastroenterology, of course, and she's the vice president of the United European Gastroenterology since last October. She is dedicated predominantly to hepatology, particularly to alcoholic and non-alcoholic fatty liver, nutrition, and public health. She's full professor at the Faculty of Medicine in Lisbon since 2017, and her long-range activities include teaching pre- and postgraduate students. She's also director of a master's degree in clinical nutrition and coordinates several disciplines in the area of medicine and gastroenterology from the integrated mastership in medicine and nutrition science. She is the director of Clínica Universitária Gastroenterologia of Faculty of Medicine in Lisbon, and she coordinates the hepatology unit of Centro Hospitalar Lisboa Norte, Portugal. Welcome, Helena.
Hello. Hello, everybody. Thank you.
We'll also have Dr. Raul Rosenthal from USA. He's the chief of minimally invasive surgery and bariatric surgery and the director of fellowship in minimally invasive and bariatric surgery at Cleveland Clinic, Florida, USA. He's the current president of IFSO, North American chapter, and member of the IFSO executive board. Welcome.
Morning. Thank you for having me.
And finally, but not least, we have Dr. Francesco Rubino from UK, who is the chair of metabolic and bariatric surgery at King's College London, and honorary consultant at King's College Hospital. He is one of the world's leaders in research, teaching, and practice of metabolic and weight loss surgery. He graduated in Rome at Catholic University, and he completed fellowships at the European Institute of Telesurgery in Strasbourg, Mount Sinai Medical Center in New York, and Cleveland Clinic. He is the recipient of numerous awards and given hundreds of presentations throughout the world, just like the one we are going to hear in a moment. And for several consecutive years, Professor Rubin was selected by many popular US News and World Report and Castle Connolly as one of the America's top doctors. Welcome, Dr. Francesco Rubino.
Good morning. Thanks for having me.
So dear attendees, please do sit back be comfortable and be ready for some stimulating presentations. At the end of the presentations, there will be opportunities for you to ask questions. So I'm going to start off with a poll. This is a question I'd like you to read and answer. You have 60 seconds, or 120 seconds to answer this question, which is on the first topic, which is regarding the prevalence of non-alcoholic fatty liver disease in obese individuals. What do you consider is the approximate percentage? So please vote using the dashboard on the right of your screen. While you're answering that, I might ask Helena to comment on non-alcoholic fatty liver disease as she sees them in her clinical setting. Helena, what do you think, how many of your patients you're seeing have non-alcoholic fatty liver disease?
Well, as I am really dealing with this pathology for a long time, in my hepatology clinic, I would say like 3/4 of my patients. Increasingly important is the percentage of patients that already have advanced liver disease. And in the beginning, that was not like that. But recently, we are seeing increasingly patients already in the cirrhotic phase. So I really think this is a major problem, and it has been increasingly important, not only in the prevalence, but also in the severity. But I'm really interested in knowing what is going to be the answers to this poll, because I think we all are aware that Nafld is very frequent in the general population, but to which extent is it so more frequent in obese individuals? That's what I'm looking forward to see. What is the opinion? Yes.
Yes, that'll be interesting to see, because do you think that we're seeing more of this because we were more aware of it and we're looking for it, whereas, you know, many years ago, this was not an entity at all?
Well, I think that both are the reasons. I think in one side, of course, we are much more aware and we diagnose it if we diagnose it more frequently. But I'm sure that the impressive increase that has been seen in obesity is a large contributor to this increase in Nafld, because it really matches very well at the increase in the prevalence of obesity. Okay, so I think I already have the results of the poll. May I comment on it, Lilian?
Yes, of course.
Well, you were right. The right answer, at least according to recent studies that I'm going to show next, it is about 65%. So the majority have given the right answer. It is 65%. Of course, we are considering obesity. In general, we are not considering, for example, morbid obesity, because if it was morbid obesity, this prevalence would be much higher. So it is in fact almost 3/4 of the patients that have obesity that will have Nafld. And so this is in fact a major issue. I see that some of you consider 25%. 25% is just the general prevalence in the population, as you will see next. In fact, if it was morbid obesity, it could be about 90% that should have Nafld. So, and this is, we are also going to discuss that in the presentation. Also for diabetes, in diabetic patients, we also have very high prevalence of Nafld, a little bit less than this 65%, but still quite high.
Okay, Helena, I think the audience is ready for your presentation. Let's start.
Okay, so okay, thank you very much. Hello, dear colleagues. It is a great pleasure and honor for me to be presenting on this webinar on obesity, an ongoing pandemic, and to talk with you about obesity and non-alcoholic fatty liver disease. In fact, obesity is a major problem worldwide, and it has tripled the prevalence of obesity worldwide since 1975. And in fact, in 2016, more than 1 billion of 1.9 billion adults were overweight. Of this, 650 million were obese. So 39% of adults were overweight and 13% were obese. So we are facing a major problem. On the other hand, we know that non-alcoholic fatty liver disease is also present in about 25% of the adult population. Of course, areas of the world such as the Middle East or South America have very high percentage of patients with Nafld, while others such as Africa have much lower prevalences. But what is it in fact Nafld or non-alcoholic fatty liver disease? It is a spectrum of disease characterized by the presence of steatosis in the absence of harmful alcohol consumption. And we know that about 25% of the normal livers will develop Nafld, and 20% of those with Nafld will eventually develop non-alcoholic steatohepatitis or NASH. That is characterized by the presence of hepatocyte ballooning and lobular inflammation, besides the presence of steatosis. And in NASH, we have very different degrees of fibrosis. We have patients with severe degrees of fibrosis and others with less severe degrees of fibrosis. And then 20% of these patients with NASH will develop cirrhosis. And in the meantime, there's always a very significant risk for these patients to develop hepatocellular carcinoma or to develop cardiovascular disease. And this makes them in a very significant risk. What about the relation of Nafld with obesity? We know that the prevalence of Nafld in obese is about 65%, while non-obese individuals have only 14% of them have Nafld. When we look at pediatrics, that is something that's always very worrisome. We know that in obese children with a mean age of 13 years, about 26% will in fact have Nafld. And that's very much, that's a worry because these are individuals that have still a long way to go and so have a high risk of developing more advanced stages of the fatty liver disease. In fact, when we look the other way around, the prevalence of obesity in Nafld, we know that 2/3 of the Nafld patients were obese, according to this meta-analysis of the data from the National Health Examination Survey from 1999 to 2016. And although these 2/3 were obese, that percentage was lower in the individuals that had been born outside the US. And it's interesting to know that, for example, in some ethnic groups, like the Hispanic or the Asian individuals, the percentage of non-obese with Nafld is higher when compared with white or black ethnicity. And this raises the issue of the probable great importance of the genetic factors as a risk factor for developing Nafld and NASH. In China, we have also seen a parallel increase in the prevalence of Nafld and obesity. So together with the GDP, we see here the increase of GDP, and it parallels Nafld and it parallels obesity. Also, the same is seen for US, although in a more gradual way than it has been seen in China. But the relation of obesity with non-alcoholic fatty liver disease is different in the different phases of life. Probably in early life, at birth or in early childhood, the genetic factors are much more important, such as, for example, the PNPLA3, that's a risk factor either for obesity or for Nafld. And also some epigenetic factors, such as high or low weight at birth. Later in life, in early adulthood and in adulthood, it is probably the factors related with lifestyles, such as unhealthy diet with high calorie, high fructose enriched food and Western diet, as well as the low habitual physical activity. And then later in life, it is probably the comorbidities such as diabetes, cardiovascular disease, or osteoarticular disorders that become more important. So it is possible that in the beginning we have insulin resistance, followed by overweight and obesity, then Nafld with different degrees of severity, and finally, cardiovascular disease and diabetes, although this order can be reversed or be in another way. One of the evidences of this relation of Nafld with insulin resistance is the prevalence of Nafld in type 2 diabetes. According to this systemic review and meta-analysis, the global prevalence of Nafld among type 2 diabetes patients is 55%, what's really very high. Of course, again, it's different according to the different areas of the world, but still, this is a very significant number. And this has important implications for screening, what we can discuss in the end. The link between insulin resistance and Nafld, the link between Nafld and diabetes is probably insulin resistance and is also the main risk factor for Nafld, at least as we now are aware. And the decrease in insulin sensitivity usually precedes the development of Nafld, although sometimes it is not obvious. Another evidence of the importance of obesity to NASH is that in the patients that are able to lose about 10% of their weight, this is according to this study from Villar Gomez, published some years ago, we can see that after these 52 weeks of lifestyle intervention, if the patient is able to lose 10% of his weight, the probabilities of NASH resolution, fibrosis regression, osteotosis improvement are quite high. The problem is that the patients that achieve this weight loss is really quite low. On the other hand, the patients that lose less than 5% of their weight, the probabilities of NASH resolution, fibrosis regression, and steatosis improvement are much less. So there is a very strong relation. Also, we know that many of the clinical studies that are ongoing, that are on pipeline, and there is a great number of studies, those studies that are also effective on weight loss, such as, for example, the GLP-1 receptor agonists, have been shown to be quite effective in the treatment of Nafld. And the other very important evidence is regarding the effect of bariatric surgery. According to this study from the group of Philippe Mathurin from La Salle, he has shown that the resolution of NASH associates to a marked weight loss, and also that after 5 years after bariatric surgery, the percentage of individuals that come to have F0 fibrosis increases tremendously. This is just an example of how the histological improvement can be quite impressive. This is baseline. This is after 1 year, where there's always a marked decrease of steatosis. And after 5 years, the histological picture is almost normal. So that's really something very, very impressive. So in summary, I think we may say that Nafld is strongly associated with obesity. There's evidence that weight gain in hypertriglyceridemia usually precedes Nafld, and that treatment that are effective in weight loss are usually very effective in the treatment of NASH. But I would not finish without showing you the IFSO policy recommendation, the policy statements. And in fact, what it is stated is that obesity is feeding the rise in non-alcoholic fatty liver disease across Europe. And most of the the policy recommendations, are in the sense of reducing obesity, such as, for example, restricting advertising and marketing to children of sugar and salted beverages and industrially processed foods. And all these measures that aim, in fact, to decrease obesity. So thank you very much, and I'm now willing to discuss with you whatever you think it's useful. Thank you very much.
Thank you, Helena. That's a wonderful start to this session. Thank you very much. I think we'll just keep moving. So Guliami, I'll just get you to start the second poll.
Perfect, thank you. Great start, and we'll move to another topic. But before the other topic, there's a very interesting question, and that we would like all of you to answer and to address. And the question is, how is obesity perceived by the population? Wondering if obesity is not a disease, obesity is the main reason for joint disease, obesity is a serious health risk, as serious as cancer, or none of the above. In fact, Raul, which is going to address the topic obesity and cancer, Raul Rosenthal, would you make any comment or any suggestion about this feeling about the population? We know that our UN Secretary General is really concerned with this, hopefully and thankfully, because he understands exactly the impact that obesity has in the world. But what do you think about the population? What is our expectation about what the population thinks about this?
Yeah, thank you, Guillermo. And thank you again, IFSO, for this opportunity to participate. As I was the president of the American Society of Bariatric Surgeons in 2016, I set up a poll because I was curious to understand how is it possible that having a tool like bariatric surgery that is so safe and efficacious, patients do not seek treatment by surgery. My first thought was that it was fear to surgery. Nobody wants to have a procedure done. The second one was the lack of insurance access. What I never thought is that denial was going to be the #1 reason. People don't see themselves as being candidates for surgery or them being the ones who need treatment. Another finding from our poll was to figure out how the population perceived the obesity disease compared to other disease processes. And I won't say stunned, but I was very pleased to see that within that poll, the population perceived that obesity is a serious risk to their health, #1, and #2, as serious as cancer. But still, I felt like there's a way to go to remove that component of denial. So despite them seeing the disease as being a threat to their health, they don't see themselves as being the ones affected by that. And that is probably because obesity has become so common in America, specifically when 60% of the population is overweight. When you look at each other, we all look alike and everyone is smiling, everyone is happy. But this is a silent disease that sooner or later is going to take your life. And while most of us talk all the time about diabetes and sleep apnea and hypertension and cardiovascular disease, cancer is a serious, serious problem. And it is significantly associated to the metabolic syndrome and diabetes, as you will see in a few moments when I present the evidence of what I've been collecting from the literature.
Okay, and now we have the results of the poll. Any comment on these answers?
Not surprised at all that this is what we are perceiving. That's the reason for the denial. They don't see that they are sick. They think that they have a cosmetic problem. I tell you, when patients come to my office seeking surgery and have no comorbidity, which is not unusual in the BMIs of 40 to 50, I tell them, well, a good reason why you're doing this also is to prevent you from having cancer. And they look at me, they say, what do you mean cancer? So you will see in a few when I show the numbers, they are stunning. And that the world is still debating, that we're still fighting with insurance carriers to cover this procedure. It is also not understandable.
Okay, very well. So then, Raul, please enlighten us about this very important topic, obesity and cancer.
Thank you for the opportunity.
Good afternoon. I'd like to thank IFSO and the World Digestive Health Day for the opportunity to present today on this topic, cancer, obesity, and bariatric surgery. In a survey done by the American Society of Metabolic and Bariatric Surgery in 2016, entitled Obesity in America, that was published in SWORD, we found out that 86% of American citizens view obesity as a very high risk to a person's overall health. But what was telling in that survey was that 81% of those who participated felt like obesity was as serious as cancer. It doesn't come as a surprise to know that 640 million people are affected by the obesity disease worldwide, increasing the risk of 13 different types of cancer, many of those related to the gastrointestinal tract. The physiopathology, how obesity triggers cancer, is incompletely understood. It is multifactorial, related to metabolomics, to insulin resistance, steroids, and dysregulated metabolism. There are 67 metabolites that are associated with BMI and breast cancer, as an example. Talking about insulin resistance, we know about the prevalence of diabetes worldwide, which is associated to the obesity disease being the #1 reason for type 2 diabetes. You can see that by 2030, in the United States of America, we'll have 67 million of our citizens affected by the obesity disease, Europe 48 million, Middle East 42 million, Asia Pacific region about 190 million by 2030 that will be affected by the obesity disease and type 2 diabetes. What was telling to me was a paper published by Moore and others in 2014 that observed that there was a 200% increase in the risk of cancer among adults with overweight and elevated blood sugar, compared to 50% increased risk of cancer by adults that were overweight and had a normal glucose. So we are saying that obesity and diabetes result in cancer. Also interesting was what the Centers for Disease and Control Prevention published in 2017, showing that 40% of all cancers in the United States of America were related to obesity. Overweight and obesity was linked to 55% of cancer in women and 24% of cancer in men. That included esophageal, gastric, liver, kidney, and colorectal cancer increased by 30%. Not surprising was Ted Adams' publication looking at the impacts of long-term morbidity after undergoing bariatric surgery, showing that those who lost weight had a decreased mortality by 40%, but 60% of those who died because of cancer. In another study from the Kaiser Permanente group, showing a 10-year survey of patients that underwent bariatric surgery or didn't and were obese, what they showed in a very well-matched cohort of 22,000 patients that underwent bariatric surgery compared to 66,000 that did not, that those who had bariatric surgery had a much higher cancer-free survival than those who did not. And this was not only for obesity-associated cancer, also for those who were not associated to obesity. They also looked at the amount of weight loss, if that had an impact in the prevalence of cancer. And what they found out, comparing 18,000 bariatric cases versus 40,000 non-bariatric cases in obese subjects, that the more weight you lost, the less the likelihood that you were going to develop cancer. They concluded that patients that had bariatric surgery had a 14% cancer risk reduction for each 10% of weight loss. We can see in many other manuscripts published in the literature the association between obesity, metabolic health, and, for instance, colorectal cancer. 400,000 Korean adults showed a higher incidence of colon cancer if they were obese. The same thing with pancreatic cancer being the third leading cause of cancer death worldwide, showing that bariatric surgery showed durable weight loss and decreased the incidence of pancreatic cancer. In a publication from our group, looking at the NIS patient sample database, we compared a very large population in a period of time of 4 years between obese subjects with and without bariatric surgery. And what we found out was, independently of variables like hypertension, age, gender, and genetic predisposition, when looking at 1.5 million obese subjects without bariatric surgery and compare them those to 250,000 with bariatric surgery, that the likelihood of them developing cancer was significantly decreased if these patients underwent weight loss surgery. The odds ratio was 1.21 for the bariatric case compared to the non-bariatric case. Same thing, the likelihood of developing obesity-related cancer was 25.5% for the bariatric surgery versus 37% for the non-bariatric case series, showing an odds ratio of 1.7. So what is going on? Why is obesity related to cancer and bariatric surgery seems to have a positive impact in decreasing the incidence of cancer? Well, everything has to do apparently with the length of the chromosomes. The longer the chromosomes and the longer the telomeres, the longer we live. And there's been association between this particular hormonal and genetic effect of bariatric surgery, showing factors that influence other type of cancers like melanoma, pancreatic cancer, et cetera, showing that a change in telomere length after bariatric surgery was significant, lengthening those chromosomes. We see here from molecular genetics and metabolism, similar telomere length increase after weight loss induced by bariatric surgery, 10 years prospective study by Eben Blicher. The take-home message here is that there are similar scenarios and there is a call to action here. The obesity disease is a pandemic. The pandemic carries diabetes, increasing the likelihood of cancer by 200%. Tom Friedman, one of my favorite writers, in one of his last books, Thank You for Being Late, talks about that we're living in special times, the age of acceleration, technological disruption, climate change, nuclear war, and we should be afraid of Mother Nature. But how about obesity? How come they don't mention obesity? Another favorite writer of mine, Noah Yuval Harari, talks about that we're living in times of adaptation, natural selection, intelligent design, and that humans will develop bodies and brains and minds converting into cyborgs. Well, this doesn't look like that. Look at the increased number of obesity in the world, with the United States being the world champ, that it's going to happen by 2030. More than cyborgs, I think the obesity disease is converting us to severely and super obese individuals with a very high risk to metabolic disorders and cancer. In 2012, 56 million people died throughout the world. 600,000 of them died due to human violence. War killed 120,000. Crime, 500,000. 1.5 million died of diabetes. More people are dying from old age than disease. More people are dying from suicide than violence. And more people are dying from obesity than starvation. We can say that while humanity has been able to overcome famine, plague, and wars, obesity has become a pandemic and it's out of control and continues to spread. In 2021, sugar is far more dangerous and life-threatening than gunpowder. We are our own worst enemies. So I'm asking you today to look at bariatric surgery as a source to treat the severe obesity disease, not only to prevent metabolic disorders, but also to decrease the likelihood of cancer. And I thank you for your attention.
Thank you, Raul, for this very impressive presentation. And I hope this really can make some changes in the way as we all look into obesity. Thank you.
Thank you.
Well, let's see if we can make some more changes. We have a third poll before the next speaker, and I'm going to launch the poll right now. So, which of the following cases represent an indication for surgical treatment of type 2 diabetes? Is it type 2 diabetes and BMI of greater than 35 kilograms per square meter? Regardless of the adequacy of glycemic control, is it diabetes and BMI between 30 and 35 if glycemic control is inadequate despite optimal medical management? Or is it type 2 diabetes with body mass index above 27.5 if glycemic control is inadequate despite optimal medical management? So please use the dashboard on the right of your screen to vote. And I'll ask Francesco Rubino, our next speaker, to make a comment about type 2 diabetes and indication for surgical treatment. Francesco, welcome.
Thank you, Lillian. I think today we can say that surgery has become a standard therapy for diabetes. It's recognized by all diabetes organizations and even typical treatment algorithms by the American Diabetes Association and European Diabetes Society are now putting surgery on the map. These are conditions where now surgery is recognized as a therapy, as a standard of care, and it's very important that physicians around the world to become aware of this, because of course these guidelines are relatively recent, and despite major organizations' efforts to circulate and disseminate this knowledge, of course many diabetes care providers are still unaware of the indications to surgical treatment. But surgical treatment is today a reality.
Thank you. Well, I think the attendees might have voted by now. So Francesco, would you like to comment on the response of our attendees?
Well, it's obviously this shows, for instance, maybe people didn't appreciate that for patients of Asian descent, the BMI is now, as a cutoff for indication to surgery, is now lowered to 27.5. People of Asian descent, as many other ethnic groups, have a different association between BMI and diabetes, and these guidelines are the first one to start to understand that link, and so start to change BMI cutoffs for different groups. I think going forward we'll be even seeing this for more groups as the risk of diabetes is at variance quite significantly across ethnic groups.
Okay, on that note, Francesco, let's hear your presentation.
Well, thank you. I'll share my screen. Here we go. And want to thank really very much for the invite. It's a pleasure for me to speak about this subject. The numbers of obesity and diabetes have been already highlighted by the esteemed previous speakers. I just want to focus on the attention on numbers of mortality related to both obesity and diabetes. We're talking about millions of lives lost every year. And if you consider the pandemic of COVID that we're just living in today, and the, of course, the impact it's having. And then you also go back and look at the fact that we have been living with a pandemic of obesity and type 2 diabetes for the past 4 decades without ever being able to flatten the curve of these epidemics. I think this is a major issue that we are dealing with, and we need to definitely be aware that it is an important one to tackle in the next few years. So the other issues that particularly diabetes, on top of obesity, diabetes, type 2 diabetes in particular, is very much associated with obesity, but has a distinct impact on in terms of mortality and morbidity, and it can affect all organs and has a significant mortality linked to its presence. But for many years, this association, epidemiological association between obesity and diabetes has been considered as a result of increased fatness. So too much fat tissue will lead to diabetes because of metabolic links. Now, what I think is happening in reality is that we're learning a lot from surgical interventions on the gastrointestinal tract, which can actually tell us perhaps about a different type of link between obesity and diabetes. In fact, my personal epiphany about this, what surgery could tell us, is this realization that what we call weight loss surgery or bariatric surgery, in reality, is an extraordinary and exquisite treatment for diabetes. In fact, the fact that it leads to rapid resolution of hyperglycemia, but also to lasting remission of the disease, at least as much as we know it for so long, speaks about a powerful effect on diabetes of these operations, maybe even more powerful than the one we see on obesity. So I was really, from the beginning, kind of puzzled by this fact that the resolution of diabetes after this surgery seems to be even more likely to occur than the resolution of obesity itself. And just to give you a sense of this, now more recently I've been looking at, with my fellows, at the last 600 consecutive cases that I operated on. We just made an audit to look at remission of obesity as in BMI less than 30 and remission of diabetes as normal glycemia with no medications. And interestingly enough, you can objectively say that the same procedures induce remission of diabetes in almost 80% of cases, but on much less frequently induce obesity remission. Now, that is not to say that surgery is not effective on obesity. In fact, it's extremely effective on severe obesity. But in terms of dealing with the whole disease and inducing the reversal of it, I think if you accept that these operations on the GI tract are a good treatment for obesity, I think you would agree with me that they're all the more acceptable and actually valuable treatments for diabetes. In fact, if you look at the effect on mortality reduction, when you look at the utilization of these procedures in patients who have obesity but without diabetes at baseline, this is just a recent meta-analysis published in The Lancet, you can see that there is almost a twofold effect in lowering mortality in people with pre-existing diabetes than in people with no diabetes at baseline. And in fact, the number needed to treat to prevent one death is significantly lower in patients with type 2 diabetes at baseline. Again, suggesting that this is operations on the GI tract are excellent for obesity, it may be even more so for diabetes. So GI surgery is an exquisite treatment for type 2 diabetes. And to me, that observation speaks about a different relationship between obesity and diabetes. The question that raises is it the fat, the missing link between obesity and diabetes, or is the gut? In fact, over the last many years, we have found that the gastrointestinal physiology is crucial for glucose metabolism. And surgical operations on the GI tract can alter each and every of those mechanisms of physiology, suggesting, of course, that the reason why diabetes is improved is not just because we decrease fatness, but because of the metabolic effects that we're doing. And this is now pretty much recognized. We now also have a substantial clinical evidence from level 1 clinical evidence, indeed, that surgery is superior to any other form of diabetes therapy, as shown by dozens of randomized clinical trials that have been published so far. So this is quite a conclusive, I would say, level of evidence. And in fact, this has been recognized by many organizations. These are the Diabetes Surgery Summit global guidelines. They're now endorsed by over 50 organizations and even by health insurers from Korea to Switzerland to now France, Brazil, and also private insurers now in the United States are recognizing the new guidelines that, as we say in the question, do suggest and recommend that surgery is considered in patients with diabetes, especially if it's poorly controlled with medications, even though their BMI might be as low as 30 or maybe 27.5 for patients of Asian descent. But one question that I think also surgery allows to answer is this idea of whether or not diabetes is a curable disease. And I think that our recent study published in The Lancet just a couple of months ago may allow us to address this question indeed. So this is a randomized trial. This is a 10-year follow-up of a randomized trial comparing surgery and medical therapy. And this is the only long-term 10-year follow-up of a randomized trial of this type so far. And this is a study that compared 2 operations by gastric bypass BPD versus medical therapy. And I want to point out that this study had an extraordinarily high retention rate at 95% at 10 years. So it's quite remarkable. We had inclusion criteria that made us recruit only patients with severe advanced diabetes. And remission of diabetes was the primary endpoint, but we also looked at various secondary endpoints pre-specified, including diabetes-related complications. The study showed that, as predictable, perhaps surgery far achieves that remission of diabetes and prolonged remission of diabetes over 10 years, whereas this is not possible by medical therapy and lifestyle interventions. Overall, there was a better glycemic control in patients who had surgery, regardless of remission. A1C levels were decreasing from baseline in surgical patients far more than in medical patients, which also the study has demonstrated thanks to good new drugs available in the market. We had an overall improvement of diabetes in the medical arm from 10 years before, which is remarkable. Nevertheless, this is not yet as close, nearly close to what surgery can do for diabetes. Surgery also resulted in better quality of life. Both operations had better quality of life results than medical therapy. And very importantly, we found that diabetes-related complications occurred far more often and significantly so in people who had medical therapies compared to surgical interventions. Also, surgery resulted in less use of medications of all sorts, particularly no requirement for insulin, even though at the beginning of the study, at least 50% of patients in the study had a need for insulin therapy, and also non-diabetes medications of all sorts, including all the ones used for cardiovascular disease, were statistically significantly reduced by surgery compared to medical therapy. So this is a very important finding in terms also of the perspective of cost effectiveness. So the American Diabetes Association, with a consensus statement some years ago, defined that diabetes remission persisting for more than 5 years as an operational cure, operationally as a cure of diabetes. And now I would suggest that this is not something that we see rarely with surgery. This is a typical patient of mine who had diabetes, had an operation, and goes on for 10 years seeing no sign whatsoever of diabetes clinically and in the laboratory. And this is our randomized study has shown happens quite substantially in more than a third of patients at 10 years. So you have, I would argue, at least a third of patients that could be potentially cured from even advanced diabetes. Again, not early diabetes, as all the patients in this study. So perhaps because of all this evidence, The Lancet has recognized on the cover page that metabolic surgery is more effective than conventional medical therapy in both short and long-term control of type 2 diabetes. But I want to conclude my presentation by highlighting a problem. A big problem we have is that despite all this evidence, despite this dramatic evidence and also this potential of curing diabetes and reducing mortality, etc., less than 0.1% than the 1% of people around the world who meet the criteria for surgery actually have access to surgery. And in many countries, this figure is actually 1.2. So what are the barriers? There are misperceptions around surgery, misconceptions around the use of surgery, and also stigma that play a role. I just want to conclude by giving you two ideas of what could be in the way of understanding and accepting surgery. If you ask healthcare providers, as we did in a congress here in London, which of the various conditions that we proposed to them could be resolved entirely by just changing lifestyle, then type 1 diabetes, cancer, osteoarthritis, people recognize that they are not resolvable just with lifestyle changes. But when it comes to both severe obesity and type 2 diabetes, still too many healthcare providers believe it's so easy to treat them as just changing your lifestyle. And in fact, in a major survey of 5,000 people in 4 countries, we asked the question, what is the most effective treatment of severe obesity or type 2 diabetes? And you can see that 80% of responders say the lifestyle intervention is the most effective treatment, despite of the fact that there is no evidence for this. So the lack of awareness, lack of knowledge about the severity of the disease, there's a misconception of the reversibility of the disease by just deciding to reverse it, is perhaps one of the barriers that comes into the way. And finally, I want to highlight the role of stigma as a major barrier. This is a study, this is just an observation we made using a study that measures stigma across various countries. And then we looked at volume of bariatric metabolic surgery in the same countries that all share a sort of national healthcare system. And you can see that in red, increasing level of stigma are associated with decreasing volumes of surgical operations per year, suggesting that in fact stigma is a major driver for the low uptake of surgery, despite now the evidence is clear. And I want to just finish with this slide because I think it's quite emblematic that a journal as conservative, a medical journal as The Lancet, certainly not a surgical journal, not very enthusiastic about surgery historically, has now believed that the evidence is so striking to put this statement, this conclusion on their cover. So surgery is more effective than any therapy we have for type 2 diabetes. Thank you.
Absolutely fascinating. Thank you, Francesco. Well, we've had 3 very good presentations. We're going to start inviting our panelists to give some comments. I'm going to start asking Lauren Beato. Lauren, you are a surgeon in Canada, and do you see in your practice increasingly number of your patients presenting with bariatric surgery, with non-alcoholic liver disease and cancers?
Yeah, increasingly so, and it's an ongoing problem. It's really emphasized the lack of awareness. Just yesterday, a 55-year-old lady with type 2 diabetes referred for bariatric surgery, and at the time of surgery, we found cirrhosis, not only NAFLD or steatohepatitis, but she had a full micronodular liver cirrhosis. So this lady could have been referred 10 years ago, and we could have prevented this evolution. So that's very common. And also in terms of cancer, yes, well, that's a good occasion when we see the patient for pre-op to check for screening, because those are very common if we look for them: colon cancer, breast cancers, and also some GI tract cancers.
Yes, we also have some of our panelists to make some comments and eventually guide through some questions to our presenters. And I would like to ask Dr. Nicola Di Lorenzo how much he was impressed with this overwhelming evidence of effect of surgery in terms of controlling a well, lots of sort of metabolic diseases, and especially tackling cancer. Dr. Nicola.
Dan, I'm sorry, I was keeping the microphone off. Sorry, I will start my talk. As Dr. Rosenthal has well depicted, the connection with cancer is so important that we cannot deny the situation. The fact is that recent papers are also presenting, 2 days ago, one was published from Portland, Oregon, saying that colon cancer is increased after bariatric surgery. So I think we should continue to study in the scientific world concerning especially the microbiota and so on, because maybe there is something that we don't understand well about data on our patients operated. But I still continue to say that we need to increase the awareness of people about the risk of cancer in our patient, overweight patients and obese patients. And this is a battle which is going on in all our countries. It's not an easy issue, but I think this is the focus and the reason also for pushing occasions like this is that we need to continue to increase the awareness of people about the risk of coming with obesity.
Yeah, I also would like to call in Dr. Saeed Hamid. We all care about liver within this topic. And the fact is that Elena presented many evidence of how obesity affects liver, but at this time, you think it's appropriate to, and that is one of the questions that was put up by our audience, is it the time to change the name? And is that only a semantic issue, or is it much more than that, changing Nafld to metabolic associated liver disease?
Thank you, Guilherme. I strongly believe that changing the name does not probably affect the patients that much. What we haven't been able to convey is how bad is a fatty liver disease to you in the end. People don't understand that this is now the biggest reason for liver transplantation in many parts of the world. It is rapidly becoming the biggest reason for liver cancer in many parts of the world. Now that we are treating hepatitis C and controlling hepatitis B. So I think it's more the awareness, the creating of awareness, and the fact that this could be prevented by many means, as we've heard, rather than changing a name. Yes, changing a name might be more useful in the scientific quarters, but I don't think it's going to affect the patients. Patients come to us to say, oh, doctor, I've got fat in my liver. What do I do? What is the risk? Those who are concerned. So that's point number one. I just wanted to make one other point or a couple of points. And one is that South Asia in particular, as you know, is now the hotbed for diabetes. 25% of our population is either diabetic or pre-diabetics. And most of them have truncal obesity, and they're going to run into trouble very, very soon and in great numbers. We've already heard the numbers, 190 million people in one of the presentations. The other point that I think we need to elaborate on and perhaps discuss is the fact that in patients with non-alcoholic fatty liver disease, we are seeing liver cancers without the presence of liver cirrhosis. So we are not going through the sequence that we are so well aware of as treating physicians of cirrhosis and then cancer and so on for hepatitis B and C. So that's scary because nobody knows how to screen these people. We very well know how to screen hepatitis B and C patients for our liver cancers. There are good algorithms there, but we really don't know how to screen these patients and when to screen these patients who have fatty liver disease for liver cancer. And none of our liver societies are yet recommending any sort of screening for these patients. So those are just a couple of points that I would like to put on the table and perhaps have a discussion around to see what the learned audience and the speakers have to say about that. Thank you.
Yeah, you're absolutely correct about the non-proven usefulness of any screening program towards liver cancer in obese patients. Further along the road, do we have a direct correlation between obesity and the amount of steatosis in the liver, which is another big issue? Because how can we be sure? Can we measure? Can we assess that? Should we rely on liver biopsies finally and again? What do you think about that?
I think we've lost the battle for liver biopsies because it's very difficult to convince people now to get biopsies. And so our next best option is to look at fibroscans and shear wave elastographies and so on, which are helpful. But obviously, being hepatologists, we've grown up with liver biopsies, and that is what we would want to do. And perhaps that is something which may need to come back for at least for fatty liver disease, if not for viral hepatitis, and we don't need that anymore. So my suggestion is we should revive the art of liver biopsy.
Right. We still have some questions from the audience, and one is also very interesting. There are lots of questions, but one of them is directly connected to the second presentation about the need, or how can we be sure that when we undergo bariatric surgery and we perform partial gastrectomies, how can we clear for sure precancerous lesions to exclude bias on eliminating early gastric cancer? Can we do that? Are we doing that regularly every time? And that was a question posed to Dr. Raul Rosenthal.
We can't hear you, Raul.
Yes, you need to. We cannot hear him. I'm not hearing the answer, and I was wondering if any of our panelists would make any comment on this issue. Yeah.
I'd be happy to comment. Yeah, there was some new guidelines that just came out a few months ago from both IFSO and ASMBS commenting on this issue. And yes, we are going more and more to a preoperative upper GI endoscopy in any patient who have GERD symptoms or who have some upper GI symptoms. And also, but this is a lower level of recommendation for patients who have bariatric surgery. It can be also recommended to have an upper GI endoscopy and to repeat this type of endoscopy every 5 years, 3 to 5 years in every patient who had bariatric surgery, because of some studies showing up to 20%, 25% of Barrett's esophagus. But in terms of esophageal cancer and gastric cancers, these are really case reports. So out of the hundreds of thousands of bariatric surgeries that are being done every year, we have only a few case reports of upper GI cancer. So it's very reassuring, but we have to follow pre-op and post-op for Barrett's.
Correct. There's also one
if I
very
can add a single word, coming from the European role is coming back. I don't know if you can.
I'm driving to the OR.
Our European.
Okay, then
I was just commenting about the fact that the European guidelines were published last year together with the European chapter. Were still stricter about the fact of having an endoscopy on most patients, or even all patients going for bariatric surgery because of the reasons you mentioned before. So it's a trend because we want to prevent things, and to control the patients after the surgery is important as well.
Interestingly, we have two very provocative questions, and I'm still not sure who is going to take this to answer. But anyway, let's see. One question: diabetes is so common. What are the clinical criteria that we have for progressing to surgery in diabetes? Should we go? When should we go? When should we propose surgery for diabetic patients? What are the numbers?
I think this is a very good question, because the guidelines that I just mentioned say that based on current evidence, patients who have certain characteristics should be all considered for surgery. But even if you buy into those guidelines, you would have millions of potential candidates for surgery, so well beyond the potential capacity of any surgical departments around the world. So the problem is how we select patients and prioritize patients with diabetes to surgery. Earlier this year, we published in the Lancet journal a consensus statement to guide and recommend how to prioritize patients. And what we said is that even in the context of surgery for diabetes, where there are many patients can benefit, there are some patients who can benefit more. So there are patients, for instance, who are on insulin, patients who have already developed cardiovascular disease. For them, the likelihood of the number of patients needed to treat to save one life is plausibly much lower, and I think those patients should be prioritized. The problem is that today, none of these patients are prioritized. Generally, a patient who presents to their doctor with diabetes is 99% of the time not informed that surgery is an option at all. And I think that's something that needs to be changed.
Correct. And Elena, we have a very interesting, another provocative question about why is the hepatologist's guidelines do not recommend surgery for obese Nafld or NASH like diabetologists? Why are liver people conservative?
Well, in what regards the American guidelines, in fact, they do not recommend. I think it's because there were rather few studies demonstrating, well, the effect on patients with Nafld, besides the effect resulting from the weight loss. However, the European guidelines, the last European guidelines that are already from 2016, already recommend that well-selected patients should be considered for bariatric surgery. So I think there is a trend, and I think probably after this study that I mentioned of Lassaï, of the group of Philippe Mathurin, with these impressive results on the resolution of NASH attaining about 84%, I think at least in the European guidelines, I think it's very possible that the next guidelines will already consider at least that inpatient, well, because also you have to be aware that guidelines say that patients that have indications per se for bariatric surgery should undergo. The issue is to do the bariatric surgery just for the treatment of Nafld NASH. And for that situation, I think that probably in the next, the very short future, it's possible that it's going to enter the guidelines.
Yeah. And endoscopy will come around.
There's also some fear always of the side effects.
Right.
Perfect. Of the morbidity and.
Lilian, would you make any question or any comments on this discussion we're having?
Yeah. I'm just reading the questions. There's many interesting questions coming in. One again on hepatic steatosis. Helena, the question is the degree of obesity correlated with the degree or the extent of hepatic steatosis?
Well, I'm not aware of any study that really correlated exactly the degree of obesity to the degree of steatosis. But the issue that I would like to mention, and it was already discussed previously with Professor Ahmed, is that the amount of steatosis is not what is more important for us when we are evaluating a patient with non-alcoholic fatty liver disease. It is much more the degree of fibrosis or the necroinflammation that's present than the degree of steatosis. And in fact, that's the reason why what I think it's really important to measure, as it was mentioned, was the degree of fibrosis by FibroScan or other methodology that measures fibrosis, because that will make the difference between those patients that will progress to end-stage liver disease, or at least to fibrotic forms of NASH, more than the degree of fibrosis per se. And in fact, we have some patients with like 80% steatosis on their livers, but don't have a really important necroinflammation or important fibrosis. So I think we have to focus, and in fact, that has been the focus much more on the degree of fibrosis.
Okay, that's another question to Raul Rosenthal about cancers. Is there a particular cancer that is most prevalent in the obese population?
Yes, I would say the most concerning one is breast cancer. 55%, as I mentioned in the presentation, of cancer in women are linked to the obesity disease, and the most concerning one is breast cancer. However, we have to say that when it comes to GI disease processes, I would be very concerned about gastroesophageal reflux disease, obesity, Barrett's esophagus, and esophageal cancer. I think we are seeing a research of adenocarcinoma of the distal esophagus because of obesity-related reflux and adipose reflux that triggers Barrett's esophagus, dysplasia, and cancer. But definitely breast cancer is number one, and as I mentioned in the presentation also, 30% increased risk of colon cancer.
Okay. Now, there's another interesting question. We know that obesity is related to hepatic steatosis, NASH, and diabetes. But why is the resolution of NASH or diabetes independent of weight loss?
Well, let me take that question. I think the idea that weight loss should be the reason why things improve is also misconceived, because weight loss is not a mechanism. It's not a physiologic mechanism. Weight loss is the consequence of physiologic changes. So pretty much like changes in glycemia, so it's weight loss, a change that occurs because of other mechanisms. But anyway, because we conceived weight loss as a mechanism for all those things, we and others have done studies to understand the weight-independent effect of surgery on diabetes, which I think now is quite consolidated as an evidence. But more recently, we also seen with Geltrude Mingrone and colleagues and myself in rodents that also the effect of surgery on NASH is weight-independent. And we are at the moment conducting a clinical study here in London to verify this findings in humans. The reason why this might be is because NASH, pretty much like diabetes, has a pathophysiologic background that includes insulin resistance, as well as other hormonal inflammatory mechanisms, all of which have been already shown to be affected by gastrointestinal surgery. So if surgery is weight independently improving diabetes, the chances, the odds are very high that it will weight independently improve NASH.
While we've got you, Francesco, someone wants to know what kind of policy and regulations would you like to implement to tackle obesity?
Well, I personally think that we need to make the picture much less blurry than it is. When we say obesity is a disease, which I do agree, for some patients it is a disease. We, however, use a blanket definition that until we define obesity in a better way, in a more clinically meaningful way, is actually like a boomerang, is kind of create a pushback against us. Because many people say, if you say obesity is a disease, then everybody with BMI over 30 has a disability, has an illness. And maybe that's not true here and now. they might have it later on, but not here and now. But nevertheless, some people have a disease here and now. So with the Lancet journal, we just are, this is confidential, but I'll share with the world today. With the Lancet journal, we are starting a Lancet commission to define clinical obesity as an entity with more clinically meaningful criteria than BMI. And so the definition of clinical obesity might not meet the definition of obesity, the condition based on BMI. So that's perhaps what I would like to see in the future. A more clinically meaningful definition that allows us to treat where we need to treat and prevent where we need to prevent. They are not the same things.
Can I add something on? Well, I'd say it more on the perspective of early prevention. And I think that countries have to think of taxation measures, taxation for the price of sugar beverages, of some kind of food. Also, I think it's very, very important to have a focus on children and on all the marketing policies, a very big difference. And in fact, in Portugal, we had some years ago, we included a taxation for sugar and salted beverages, and that resulted in a marked decrease in the consumption. We don't have yet the result in health or in the degree of obesity, but just the fact that the consumption decreases, I think it's very, very important. And also campaigns such as that one of drinking water, having water available on places. Of course, I think that bariatric surgery is important, but it's like the end of this spectrum. So I think that we have much earlier in life, try to change the way people think and the way people eat. And of course, also policies for the building of the cities to have more availability for spaces to walk, for the children to play. I think these are very, very important policy, but the governments have to be very well aware of that and do what's needed to change it. Otherwise, it will always be getting worse.
Yeah. If I can add a comment, Guilherme, yep. May I?
Sure.
Yeah. To Francesco's point, does everyone with a BMI greater than 30 consider him or herself as disabled? I don't think that every disease we suffer from necessarily will be disabling. But I think the answer is yes, because even if you are not disabled, the obesity disease keeps working while silent, while not hurting. And the development of NASH, the development of cancer, the development of cardiovascular disease, it takes time. And while the patient might be very happy and enjoying the large meals and a sedentary lifestyle, despite being obese, at some point, the alarm will sound. And by that time, there is so much that has been harmed that it's going to be very difficult to reverse with any kind of intervention. So the answer to the world is keep your BMI under 30, because otherwise, sooner than later, you will get in trouble. And in my answer is yes, obesity is a disease.
Yeah. Okay, I agree. And the fact is that that is a very important message, especially for everyone concerned with digestive oncology, which has been creating a momentum with obesity. It's clear that GERD and the complications of GERD, long-run complications of GERD, are clearly related with cancer. But in many other organs, we've seen liver, pancreas, and of course colorectal cancer. But you know, when Elena was talking about the importance of other measures, a question came up, and well, and in fact, it's still important to consider this, especially when we think globally, as our societies try to do. And that the question was, is there still a place for lifestyle interventions in primary care and in the community? How can we address that?
Maybe I can take
the answer is yeah. The answer is absolutely yes.
Yes.
We should not advocate that the first line of treatment of any disease process should be going to an operating room. So I think the answer, lifestyle interventions, counseling, surgery should be last on the list. The big question is when to intervene, and that is something that we don't have the formula at this point. Thank you.
May I add to that question, because I think it's a perfect question to meet with what Raul was saying about disease, non-disease. When you use lifestyle interventions, you would do so either for other diseases, either as a complement to therapy, so treatment, or as a preventative measure in patients who still do not have a disease. So yes, the question is lifestyle interventions should be implemented globally to prevent severe obesity, to prevent diabetes, and sometimes to complement treatments. The problem we have is that lifestyle interventions used as a treatment of disease is a misconception, because when you have a disease, then it's past the point of lifestyle intervention. You need a medical intervention. Now, back to Raul's question about disease, not disease. The fact of having a condition of risk for future cancer, diabetes, or NASH, or everything you want, doesn't constitute evidence for disease here and now. Disease entities are normally categorized because of a number of other factors. And so what I'm saying is that, yes, obesity can be a disease, but if we measure with the wrong metrics, we are actually overdiagnosing the problem in some, and we're underdiagnosing the clinical entity in others. That's why we need a better definition than the WHO current BMI-based definition. Otherwise, we're not going to move on from this impasse.
Thank you. Lillian?
One more question on cancer, Raul, from the audience. They want to know if the specific type of bariatric surgery, is there one better than the other as a benefit for longer survival or prevention of cancers?
There is no evidence in the literature, level 1 evidence, that can support the one procedure versus the other. I think we see under the umbrella of weight loss so much good happening that I would say any procedure, any intervention that can help you not only lose your weight but keep the weight down should be considered as a treatment modality. But if it is going to be the BPD or the bypass or the sleeve, that depends on the patient, on the disease, on the BMI, on the comorbidities. There are so many factors that are going to affect which surgery to choose. But any of those will result in weight loss, and I think that's where we see the positive effects of bariatric surgery.
All right, I think that's a very good note to wrap up this session. It's been a very interesting and fascinating talks and discussion from everyone. So I'd like to thank all the speakers and the panelists for their time and their contribution. It's a great start to the World Health Digestive Day, and I look forward to the next session. So thank you, everyone.
Thank you, bye.